We're now engaged in a study to look more broadly at the question of the use of bypass surgery, that is CABG, versus percutaneous coronary interventions, because those are competing approaches to individuals with coronary artery disease, and there is oftentimes not clear indications about which patient would benefit from which. So some 80,000 patients are being assessed here to look at long-term clinical and cost outcomes of these two possibilities in a study that is now affectionately known as the CABG patch study, of course. And looking at outcomes, as you can see here, this is ongoing, looking at subsets of the data because you want to be sure you're not lumping things together so much that you miss signals from subsets of the patients, something I'll come to in a moment in terms of being sure we don't lose personalized information in CER studies. Another study which is underway, which is much assisted by dollars from the Recovery Act, is called SPRINT. This is an effort to try to understand whether there's additional benefit to reducing the systolic blood pressure from the current 140 upper level down to 120. And again, that can imagine it might do some good, but it might also inspire risks because you are pushing people down into a zone where you might have hypotensive episodes. 7,500 participants, and with an additional cohort from the Recovery Act of elderly patients, 75 and older, to see whether, in fact, there is a difference in the outcome in this group that you might imagine could have somewhat more of a fragile state. And a sub-study also looking to see whether there's influence in terms of cognition in this same kind of management of blood pressure, either of a positive or a negative sort. One thing that I wanted to tell you about, which is not a specific study, but is more of a laboratory or a collaboratory to allow us to conduct additional studies in CER, is this consortium of some 16 integrated health systems, which together cover more than 13 million people. You can see from the map of the US where these are located. Many of them have the name Kaiser attached to them, but this also includes others like Marshfield and Geisinger and so on. This group has been working together already for a few years on specific studies funded by NIH, and have also had a very strong relationship with ARC. My sense was that we might be able to do even more with this network than had previously been the case. And so we are utilizing funds from the NIH Common Fund, which is a part of our budget that can be applied to problems that are not specific to one of those 27 institutes but might benefit all, to see if we can build up the infrastructure of this HMO research network and put them in a position to be a rapid response kind of network for questions that come up where you'd really like to get an answer quickly and efficiently without having to build a whole structure and then tear it down when you're done. And you can imagine this could be useful, for instance, for looking at adverse effects of new medicines that have recently been released and which are being applied to lots of people, or looking at pharmacogenomics. Could even be used, I suppose, to look at practitioner incentives to try to understand how that influences medical care, if you could do that in a controlled fashion. So we're excited about this as yet another way to push this agenda forward. And certainly the HMO Research Network has been quite willing to engage in this, and I think are actually themselves quite pleased at the chance to play a larger role in research as a consequence of this kind of structure. Carolyn and I wrote an article, which I refer you to, in Science Translational Medicine about PCORI, and I know much has already been said about this, and I'm not going to say anything much more other than to say how interesting it's going to be to see how this plays out, and how gratified we are to see the way in which this should supply additional support for this critical kind of research. The graph you see there is our best guess, but it is a guess about what the dollars actually will be that will flow to CER through PCORI, because while there are appropriated funds, which are specifically enumerated in the bill, the green there is an estimate based upon the TAPs that will begin to kick in 2013 and grow over the next 6 years on healthcare plans, and we don't really quite know what that will come out to be. But it certainly seems possible that by 2017 or thereabouts, PCORI will be working with a budget somewhere in the neighborhood of $500 million, which is something you ought to be able to do quite a lot with. And we will be very interested to see on September 23rd when the members of the PCORI board are announced exactly how is this going to play out as far as leadership. Carolyn and I will both be on the board. We are excited about that opportunity and think that this is in some ways going to be an extension in an ongoing way of what the IOM tried to do in a big hurry a little more than a year ago. Basically surveying the landscape, identifying where the needs are, and then sort of sending up a flare and saying, okay, we need this done, we have some money for it, who wants to play? And I think NIH will be quite regularly interested in playing if it fits into our area of strength, which is primarily to conduct primary research in this fashion that I've already described by these examples, with trials that involve rigorous study design and ideally circumstances that are randomized and controlled, although there will certainly be observational trials as well that both we and ARC will be interested in pursuing. Finally, I just want to say that there have been some suggestions in various quarters that maybe CER and personalized medicine are on a collision course. And the argument goes like this, that CER is really only interested in looking at very large numbers of people that are randomly divided into two different interventions, and there's just one answer about which intervention worked and the other one didn't, and so that's that. Of course, there are subsets of individuals who may respond differently, and you can imagine a circumstance where you could actually do harm if a subset of individuals who actually were getting a very good response were lost in the shuffle because there were not enough of them to basically be seen in the analysis. They would be diluted out, and the opposite therapy might be chosen in the main because it happened to work a little better for the majority. We would not want to have that happen, and I think there are reasonable ways in place to make sure that designs are put forward to avoid that kind of outcome. After all, CER studies in the modern era really should include participant genomic and environmental exposure data so that one doesn't lump everybody together but actually looks at subsets to be sure there's not a signal there indicating that there are individuals that have a different response than when you put everybody into the same boat. And that is something NIH is used to doing in terms of evaluating subsets and recognizing all the statistical implications of doing so that you don't fall into a trap of multiple comparisons that causes you to draw conclusions you can't later justify. I think as an example of the kinds of things that we need to be thinking about, certainly if we're talking about comparative effectiveness of any kind of a drug trial between two different drugs, and I already cited a couple of them in the previous examples, you need to keep in mind that people's response to drugs is likely to be different because of individual genetic differences. A classic example right now is clopidogrel, very highly prescribed drug, which works quite nicely to prevent platelets from forming clots and is particularly used for people at high risk of heart attack and stroke. But it is becoming clear that only about a third of people who get this drug don't receive benefit from it. And the reason for that has recently been figured out, and this was sort of the first publication, many others have now confirmed this, showing that variations in this particular gene, 2C19, is responsible for metabolizing this. Plavix is a prodrug. It doesn't obtain biological activity until it's converted to the active form. If you're low in the activity of the enzyme that does that conversion, Plavix isn't going to help you. And that is true of about a third of people.